Alright guys, it's quiz time. I have a question for you. What is the leading cause of low vision and blindness in working age adults? Need a hint? Yup, it's diabetes mellitus. Diabetes can damage the retina and lead to other blinding complications such as glaucoma and cataract. But in today's video, I will go through how diabetes affects the retina and how we can leave diabetes-related cataract and glaucoma in the future videos. That's today's video. Let's take a look. Hi everyone, welcome to today's video. This channel dedicated to providing you with the most comprehensive and up-to-date eye health information so you know how to take care of your eye and vision. But most importantly, I don't want you to hear about eye disease and go online searching about it because very likely you come in touch with some frightening and misleading articles written by nobody that scare the crap out of you and you ultimately freak out and say, hey, am I going blind? It's the end of the world. No, I don't want you to feel that way. The information in my videos is as objective as it can be with neither understatement nor exaggeration. If I made a mistake in my video or you have any suggestion for me, don't hesitate and put them in the comment section below. That being said, let's dive into today's video. Diabetes mellitus is a disease in which the body cannot produce or respond to a hormone called insulin, causing abnormal metabolism of carbohydrates and elevated levels of sugar in the blood and urine. Whatever types of diabetes you have, your eyes will be largely affected the same. The problem with diabetes is that all of the blood vessels throughout your body get damaged, and this is significant because to some extent, we are only as old as our blood vessels are. Most people know that diabetes can lead to amputation, peripheral neuropathy, cardiovascular disease, and kidney damage, but not all know that because the back of the eye is highly metabolically active and rich in blood vessels, diabetes can also damage the eye. Diabetes leads to a retinal disease called diabetic retinopathy. This is the eye disease that nearly all diabetic patients will eventually suffer from. 20 years after the onset of diabetes, almost all patients with type 1 diabetes and over 60% of patients with type 2 diabetes will have some degree of retinopathy. When many diabetic patients hear from their physicians that they need eye screening, they don't know what for. After watching this video, I hope everyone knows what is going on with the eye if the patient has diabetes. If you have diabetes, don't worry because while blindness is one of the most feared complications of diabetes, it is also one of the most preventable. Now, diabetic retinopathy is divided into the non-proliferative stage and the proliferative stage. The word proliferative means whenever abnormal blood vessels grow into the retina. Patients will always start off with the non-proliferative state, and if the retinopathy is not well managed, they will go on to develop the proliferative stage of the disease. So the vessel walls of the retinal capillaries consist of endothelial cells, parasites, and basement membrane. Endothelial cells form a single cell layer that lines all blood vessels and regularly exchanges between the bloodstream and the surrounding tissues. The parasite engulf the endothelial cells and their cytoplasmic processes. When coming in touch with the endothelial cells, inhibit the proliferation of these cells. The ratio between the parasite and the endothelial cells is roughly 1:1, and this balance maintains the integrity of the retinal capillaries. If the patient is diabetic, hyperglycemia will impair parasite inositol absorption and synthesis. Without inositol, parasites are unable to perform DNA synthesis, which will result in reduced cell proliferation and ultimately cell death. Loss of parasites lead to uncontrolled proliferation of endothelial cells and decreased resistance of retinal capillaries. In this patient, fundus examination of the eyes revealed these tiny, reddish balloon-like outposts called microaneurysms. Microaneurysms are the earliest lesions of diabetic retinopathy, and as you can see in this photo, these large vessels here are normal, but if you look closely, you can see these little red spots commonly found around retinal capillaries or areas of non-perfusion. These are microaneurysms. If your eye doctors find these tiny little red dots during your fundus examination, usually 2 to 4 or sometimes all the way to 20 some in a single quadrant, which is like a fourth of the retina, they will likely diagnose you of the mild stage of non-proliferative diabetic retinopathy. When doctors diagnose you with mild NPDR, they might ask you how long you've been diabetic and how well you manage your blood sugar, blood pressure, and blood lipid. If you don't know you have diabetes, your eye doctors might refer you to an endocrinologist to find out if you actually have the disease. If you do, you will have to start treatment as soon as possible. Without proper disease management, you can go on and develop the moderate stage of non-proliferative diabetic retinopathy. In moderate NPDR, fundus examination reveals spot-like hemorrhages on the retina due to damages to the capillaries. These tiny little hemorrhages might be difficult to distinguish from microaneurysms, but in fundus fluorescein angiography, the hemorrhages look dark while your microaneurysms look bright. Also, the hemorrhages can be absorbed and disappear over time, while your microaneurysms are long-lasting. In more severe cases, more extensive hemorrhages can occur. The hemorrhages can occur in any layer of the retina and can have different sizes and shapes. Hemorrhages in the nerve fiber layers are usually flame-shaped, while hemorrhages in deeper layers are usually dotted or patchy. If the hemorrhages occur near the macula, vision will be affected. In addition to hemorrhages, doctors can also see hard exudates at the back of the eye. The hyperglycemia in diabetes damages the parasites and endothelial cells of retinal capillaries. As a result, the vascular permeability increases, retinal capillaries widen, and the blood-retinal barrier falls apart. Blood, fluid, and lipids from damaged blood vessels and microaneurysms begin to ooze out and leak into the retina, forming these tiny little yellowish spots of deposits called hard exudates. These hard exudates are located in avascular regions of the retina, so they get absorbed very slowly and usually take several months to completely disappear. Finally, degeneration of the parasite and endothelial cells can lead to acellular capillaries. Acellular capillaries lose their blood flow regulation, causing hyperperfusion. The increased blood pressure from hyperperfusion damages these capillaries and causes blockages. As a result, the retina goes ischemic, not getting enough oxygen and nutrients. Decreased blood and oxygen supply will cause the nerve fibers on the retina to swell and eventually necrose. The dead nerve's axon cytoplasm deposits in the retina, forming soft exudates called cotton wool spots. As you can see in this fundus image, these cotton wool spots are usually distributed around the optic disc. They are grayish-white and have smeared out boundaries, looking like a bunch of cotton wool. If you have hard exudates, extensive hemorrhages, or cotton wool spots in addition to microaneurysms, you are said to have the moderate stage of non-proliferative diabetic retinopathy. As you can see in this photograph, with the help of fundus fluorescein angiography, the fundus with moderate NPDR looks like a starry sky because of those microaneurysms. With the moderate stage, eye doctors will be more concerned because that means that you have a higher risk of developing the proliferative stage of diabetic retinopathy, which is highly dangerous. Patients with the moderate stage really need strict control of their blood sugars. Doctors may also ask them to come in and have their eyes dilated more often to monitor the progression of the disease. When someone develops the severe stage of non-proliferative diabetic retinopathy, bigger changes will happen at the back of the eye. Not only will patients have hard exudates and cotton wool spots, but their retinal veins also begin to change shape, forming this bead-like structure called venous beadings. In addition, intraretinal microvascular abnormalities can occur. When the structures of the capillaries get damaged, terminal arterioles can become clogged up. As a result, tiny little lumpy blood vessels, almost like a ring of sausages, begin to grow in these non-perfusion regions. These abnormal blood vessels are called venous tortuosity and venous loops. These changes suggest that the retinopathy has progressed to a severe stage. Generally, if 2 or more quadrants show venous beadings or at least 1 quadrant has intraretinal microvascular abnormalities, the patient has progressed to the severe stage of non-proliferative diabetic retinopathy. During the progression of non-proliferative diabetic retinopathy, some patients can also develop diabetic papillopathy, that is, optic disc swelling. The disc edema can be unilateral or bilateral and usually affects type 1 diabetes patients. Fortunately, diabetic papillopathy is self-limiting and usually resolves within 2 months. patients usually only notice minimal visual disturbances such as painless and mild blurring or distortion, or some patients don't notice any symptoms at all. So that's good news. Now, the ultimate goal of diabetes management in eye care is to prevent you from progressing to proliferative diabetic retinopathy. That is, new abnormal blood vessels begin growing into the retina, optic nerve head, and vitreous humor. PDR can cause serious complications such as significant macular edema, vitreous hemorrhage, neovascular glaucoma, and tractional retinal detachment, which can lead to permanent and irreversible vision loss. This is not the kind of low vision that, oh, we can just get a pair of glasses. No, we're talking about permanent blindness here. People go blind for these conditions. Proliferative diabetic retinopathy is pretty complicated, so we will leave it to our next video. So, how often do diabetic patients need to have eye exams? Diabetic patients require more frequent eye exams compared to the general population. American Academy of Ophthalmology recommends all type 1 diabetes patients have a complete eye exam with dilation within 5 years of diagnosis. On the other hand, because type 2 usually goes unnoticed for quite a while, patients should get their eyes screened as soon as possible upon diagnosis. After that, all diabetic patients should receive eye exams once a year. If patients have a moderate stage of non-proliferative diabetic retinopathy, doctors will bump it up to once every 6 months. For patients with macular edema, severe NPDR, or PDR, doctors will need to see them once every 2 to 4 months. Doctors will also have to perform fundus fluorescein angiography more often for these patients in addition to dilation to closely examine the back of their eyes. Alright, I hope this video not only gives you a rough idea of what diabetic retinopathy is, but also tells you how important eye exams are. Eye exams can spot eye diseases early, but at the same time, they can also pick up many other systemic diseases that often go unnoticed at earlier stages. If you haven't had an eye exam in the past few years, schedule one, even if you think your vision is fantastic. I also hope you can sit down, appreciate, and be grateful for your good vision, your ability to see fine details, light, and colors. Finally, if you have already developed retinopathy, be rest assured because more than likely, as long as you work hard at controlling your blood sugar and do everything your endocrinologist tells you, you will at least maintain a decent amount of vision in your lifetime. Alright, thank you for watching, take care of yourself, and be well.